Hi there, everyone, and thank you so much for joining today's webinar. My name is Jeremy, and I am a representative of EHN Canada. We are a nationwide network of treatment centers for addiction, trauma, and mental health. We have facilities located in Nanaimo, British Columbia, Calgary, Alberta, Toronto and Peterborough, Ontario, Montreal, Quebec, and Annapolis County, Nova Scotia. We offer high-quality inpatient, outpatient, and online treatment programs. For more information, please visit our website at ehncanada.com. Just in terms of some housekeeping, everyone is on mute and cameras are off for today's webinar, but please feel free to use the Q&A box at the bottom of your screen to submit questions for our speaker. We will try to get to as many questions as we can at the end of the session. Today's webinar is in fact being recorded, and we will be sending out a follow-up email next week that will include the link to the video, the slides, and any other useful resources, as well as your CEU certificate. I am currently located in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabeg, the Chippewa, and the Haudenosaunee and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. We also have presence in today's webinar located at our Edgewood facility in Nanaimo, British Columbia. Christina is on the traditional and unceded territory of the Coast Salish peoples, the traditional territory of the Snuneymuxw First Nation. Vancouver is on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. If you are new to this work and want to find out whose land you are on or grew up on, please check out www.native-land.ca. Many more of you may be physically present elsewhere, so I encourage you to use the chat function to, where applicable, share whose land you're on. Now to get to today's session, the effectiveness of inpatient treatment for substance use disorder. We have the pleasure of having Dr. Christina Basedow. Christina has a strong passion for working in the addictions field. She has been working with individuals, couples, and families struggling with substance misuse issues, mental health disorders, and codependency issues. Christina is skilled in a variety of areas, including family counseling, eating disorders, sexual compulsions, and CBT/DBT. Christina brings her personal experience, compassion, and a wealth of knowledge in psychology, research, and teaching to her clients and to EHN. Christina is registered with the BC Association of Registered Clinical Counselors and holds a PhD in psychology. She is also currently a certified sex addiction therapist. Please help me welcome Christina.
Thank you so much, Jeremy. Nice to be here with all of you today. I'm very excited to present on this topic. Hopefully it will be engaging. So I wanted to start off, the introduction's already there, so thank you for that. I'm going to try and make this as exciting as possible, really because in a lot of ways, sometimes research can be boring. I love it because I'm a bit of a research nerd. I hope there's some more of you in the audience, but we're really hoping to talk a little bit about the effectiveness of inpatient treatment. And from a broad perspective, what we know and what I've seen across both my teaching experience and my research experience is that there's actually not a tremendous amount of data on effectiveness. Now, we could all make assumptions. I think a lot of us work in the field, whether it be in inpatient settings or even outpatient settings or private practices or potentially public health settings, where we make the assumption that if we take somebody, out of their active use potentially, that we're going to see improvements and we're going to see effectiveness. But there's no real data or research to say that that's true. We just sort of assume that that's happening. And when we look at the research that we want to do across EHN and specifically at our inpatient facilities is not only how effective is inpatient treatment, but in addition to that, how effective is aftercare, access to recovery capital. These are sort of all the terms that we're going to be referring to today. So I'm going to try and make it as engaging as possible. I welcome questions at the end, of course. Anything that you have, please bring up. And we're going to walk through some research measures. We're going to talk about measures that are really useful, not only for looking at the effectiveness of inpatient, but also really looking at the effectiveness of even private practice. Some of those different tools can be used in those settings as well. So I'm excited. I hope everyone's excited. I'm going to start off though with the impact of the pandemic. And there's a lot of up and coming research, a lot of new research out there to talk about how the pandemic has impacted our mental health and substance use, both across Canada and across North America. I'll be talking about statistics from both. And this does get a lot of attention, which is a good thing because it's impacted us more than we're aware of. But it also really speaks to the importance of why we're doing the research. And when I break down the research results, I'm actually going to break them down in what we saw in intensity level pre-pandemic and during and post the pandemic. So there's going to be some really exciting and also depressing, for lack of a better term, seeing the intensity of how substance use disorders and concurrent mental health issues have been on the rise, but have also manifested. So the slides are a little bit text heavy. They don't have really engaging pictures, which I guess is why I have to be engaging, but they're really full of good info. So what we know about the pandemic, and maybe this is a really good time to actually reflect even on ourselves. I find that makes things a little bit more personal. But many of us, even without an active substance use disorder or diagnosed concurrent mental health issue, noticed elevated rates of anxiety, depression, and even overall decreased levels of psychological functioning that had come on since the beginning of the pandemic. And so that was present, and that is probably maybe something we can all relate to. Increased levels of stress among students was a big research indicator and factor that we would see, which also makes perfect sense. Sleep patterns negatively affected by the COVID-19 pandemic, of course, but that also further exacerbated health issues. And even now, I would say to argue that the world energy is intense, right? It's not only the pandemic, it's not only now that we're coming out of the pandemic, but also what's going on in the Ukraine and what's happening. We're picking up on that energy, and it does cause the exacerbation of these issues. And then in addition to that, really looking at long-term effects and residual effects of the pandemic. So we may all be starting to get excited about reduced restrictions, the ability to potentially engage in more normal activities again. But really, there are individuals that will have lasting adverse psychological consequences and effects because of the increased mental health challenges that happened during and within the pandemic. So it's important just to note that. When we looked at how people were coping, both with mandated time off, not working, reduced financial income, etc., we saw a large increase in Canadians turning to alcohol and cannabis to cope during the pandemic. Increased usage, increased day usage that maybe would have typically been in evenings or weekends became sort of a weekly affair. And of course, as we also saw a large increase in overdose deaths, which also had to do with the isolation that the pandemic caused. So what is interesting, though, is the correlation that they were doing research to show that individuals that had substance use disorders would also be more likely to contract COVID. And in addition to that, would be more likely to have worse outcomes than those without it. So those with pre-existing SUD would really show an increased risk of hospitalization, the reliance on a ventilator, and increased mortality from COVID. And that was an interesting couple of studies that were done as well. So this concurrent challenge and concurrent diagnosis really made COVID-19 even more potent for people that were struggling with substance use disorder. Now, we can hypothesize a variety of reasons, but of course we link to increased usage, isolation, and really the exacerbation of mental health symptoms that would then cause using substances to cope. So when we then shifted and looked at the primary care, a lot of us are working in professions where we were part of sort of the first responder frontline. We were seeing an increased demand for our services, an increased demand for mental health support in general, particularly anxiety and depression, which is a direct effect of the pandemic. But what is an interesting statistic too is that during this increased demand for mental health resources, we actually also saw the reduction for visits to preventative care and chronic disease management. Now, if we let that sit in for a minute and we think about what that might mean for people with challenges, both mental health challenges and substance use disorder challenges, is that individuals were less likely to seek out care for chronic diseases and for preventative care management, which means that we would see an increase in severity, potentially, of chronic diseases and also of other elements for preventative care. And that is actually a very interesting thing to process, because what it means is maybe there was more demand in different capacities, but because so much was reduced and our healthcare system was overwhelmed, individuals were not able to fully take care of themselves in the way that they maybe were before. And then, of course, increasing in crisis. So, of course, it makes sense, many of us in the field, that when we see increased anxiety levels, we see increased depression, it is no surprise, even if it's a very sad surprise, that we would include higher suicide rates, higher overdose rates. And the isolation, the exhaustion, the fear, the coping became a really predominant narrative of the COVID-19 pandemic. And it became very, very clear that many of us were dealing with clients who would be very impacted by what was happening. And then the transition to virtual care. I don't know how many of you transitioned to virtual care. I know that we increased our offerings, of course, across EHN, and many of you may have gone into virtual care counseling. And really taking a look at the benefits, but also the limitations of this care. So when we look at this type of presentation dynamic, this type of counseling dynamic online, what we know from other research is that truthfully, a lot of barriers are reduced. Some people actually really enjoy this type of setting for counseling. It can create more comfort. There's an increased level of safety. The ability to just log out and turn off if something is triggering is also sometimes a very positive thing for people to know they can do. It can reduce the barriers also for those who don't have access to transportation, et cetera. So there are massive benefits to that, and we know that those exist in the literature as well. That being said, there are also limitations. What many of us who are in private practice or even inpatient settings may notice is you pick up on a very different host of subtle cues. You have a different awareness of someone's, even physical presentation, looking at things like how is their hygiene, how are they entering your office, what are they doing? And in this, you really only, I could be wearing pajamas, right? You really only see a very small portion of who I am in these types of settings. So there were limitations. And there were also limitations for screening for other medical effects. So the impact of the pandemic and the long-lasting impact of that transition to different types of services, I would say we don't totally know the impacts of that yet. I know there's lots of research that's being done, but it's important to note that you will see these things manifest in your clientele, and we've seen them manifest in our clientele as well. So that's how the context started. So we're very lucky to work within a network that allows us access to a broad range of patients. And when I look at the ability to do research, it's like, oh my goodness, it's sort of like ripe for the picking. And of course, consent, ethics consulted, everything else, I promise all those things are done, but we really have access. If you look at a general inpatient facility, I'll use Edgewood as an example, we're taking in approximately 600 patients a year, give or take. And we're collecting data on patients, of course, with consent, and we're also able to see what type of treatments work and don't work. And so the vision and purpose of our research projects were really like, how could we implement this network wide, which is currently what we're in? How can we use our EMR or electronic medical record to really administer these types of things and allow us to track the progress of a patient? And then really, what does outcome monitoring look like? And so what I'm going to be predominantly talking about in the results section today is how effective inpatient treatment is, right? Many of us may be working in inpatient settings. That being said, we're also looking at collecting data for 1 year post-treatment, because what we do know is that when someone's in treatment, of course, the improvements we can monitor, we can track. It is incredibly difficult to track people for a year post-treatment, and that is another huge gap in the literature. And then, of course, another vision for the project is we don't only want to be a leader in healthcare, but we also want to say, hey, we actually do what we say we do. We actually cause effective change, and then we also want to publish research that's publicly accessible so that other centers, et cetera, can also operate from that. But more to the point of really caring about patient outcomes. So it's not so much about the business. It's really more about, I don't think that I would sleep very well at night if I wasn't doing treatment that did something positive for people. And I know many of us are in the helping profession because we genuinely care about how our clients, our patients do, and we actually want to, drive effective change. So that's how the vision happened of what we were doing. And so I'm going to go into an overview of the scales that we use. So I mean, it's an interesting point. We're going to go through them, and I'm going to try and explain them from both how we've used them, but also how they may be useful to you, both in a private practice setting, even if you're monitoring patients over a period of time. Of course, make sure you know how to use a scale before using a scale, but they can glean really important data, and it can be really important to actually, plan using those types of scales. So the OQ45 is a really interesting one. It's not talked about a lot, but it's actually very useful. It's 45 questions. It's fairly easy to administer, but it talks about adult patient progress in therapy. So this is not a actual scale that's used only once or only at the end. Like, this is actually can be used even on a weekly or bi-weekly basis, or if you're doing private practice, can be used at each session. And it looks at the categories of symptom distress, interpersonal relationships, and the social role or roles that the client or patient would be engaged in. And it shows what is their progress throughout therapy. And by that, I mean, what are we looking at? These are some examples of questions, but things like, I get along well with others, or I feel, extreme fatigue, or I feel unhappy in my marriage or significant relationship. And of course, again, rated on a Likert scale, and, looking at the 1 to 5 range. But this can change quite significantly from session to session, and using different interventions to actually test out the various tools of therapy, which I find really interesting. And so for us in this context, the 4 critical items that allowed us to look even more intensely at things that we see in inpatient treatment would screen for suicidal ideation, substance abuse, and then anger or violence in either work or school. So the 4 critical items looking at, I feel angry enough at work or school to do something I might regret, or I have trouble at work or school because of drinking or drug use. After heavy drinking, I need to drink the next morning, or I have thoughts of ending my life. And then that can change over time. Now, it's a very useful tool, and it also correlates to different interventions. So we at our center will actually use it on a bi-weekly basis to try and gauge where someone's at. And I find that from even a client engagement perspective, people actually really enjoy knowing where they're at. Like, there's sometimes a narrative, which many of us explore in therapy, that, may show no progress, but it could be that from a very objective standpoint, when we look at an OQ45 result, we're actually seeing, like, over time, the actual drop in symptom severity. And to be able to show that to a client can be really useful. The other thing it shows you is if you're engaging in interventions, or maybe you're, using best practice, let's say you're using dialectical behavior therapy, and you're really engaging and the client's really engaging, but you're actually seeing symptoms stay the same or symptoms increase in severity, then that would be sort of a flag to go, okay, so something's not quite working, or maybe there's something I'm not really aware of when it happens in the greater context of the client's life, or what's going on, or maybe there's exposure to different stressors that I'm unaware of. It's a great tool. And if any of you work in treatment centers or private practices, and you have a larger amount of clinicians, and you're interested in how to use this to motivate clinicians, you can actually compare and contrast across clinicians the effectiveness of different therapeutic modalities that each of them are using with a variety of patients. And I don't mean that in a critical way, or to say that, one counselor's not performing than another. That's not what I mean. But it can actually be very useful for clinicians to see that, look at how my 5 patients I'm working with are changing, or look at how, I'm noticing that I've done this training and I'm implementing these new skills, and it's really actually working for our clientele. So I'm a big believer in the OQ45, obviously, because I rambled on about that one, but it's a very good tool. So the other one we use quite often again, and these are all really useful, condensed short measures. Happy to also, show them where you can access them if you're of interest. But PCL is just a 20-item sort of short measure that really assesses the DSM-5 symptoms of PTSD, used for the purpose of monitoring symptom change during and after treatment. So really, are we noticing symptom reduction in treatment? Are the trauma therapies that we're utilizing, engaging in the trauma-informed care, is it having an effect? Also screening individuals for PTSD. We have people coming in that actually believe that they haven't maybe been exposed to trauma. They don't have symptoms of PTSD, but it turns out that really this type of a tool can actually aid in making a provisional PTSD diagnosis. And of course, then we wouldn't make diagnosis without psychologists or involvement of a psychiatrist, but it can lead that direction. These are an example of some of the questions. So again, really the criterion of the DSM for those of us who are clinically inclined, but repeated disturbing unwanted memories or disturbing dreams, the really suddenly feeling a stressful experience is happening again. Are you reliving it? Those types of questions. And administered at least sort of at the beginning, midpoint, and end of an inpatient setting, but within private practice across the time someone's seeing you, can really help identify and also show to a client that they may have some PTSD related issues that are coming up. The GAD-7, many of you will be very familiar with this as a severity measure for generalized anxiety disorder and a screening tool for generalized anxiety disorder. Again, self-administered, again, very useful. And really what's interesting for the GAD as well is it takes into account the 2-week sort of duration of time, which allows us to monitor for both inpatient and outpatient settings or private practice settings, that you're really asking about restlessness, worries, becoming easily annoyed or irritable, feeling afraid at the on edge, and really working towards coming out with outcomes of, is this a nearly everyday thing? How much are my clients or patients really affected by their generalized anxiety? Would it be useful if this hasn't shown some kind of a decrease in my, skills or tools that I'm using with these clients? Do I need to involve, psychiatry? Do I need to involve psychologists? Do I need to even involve a GP when it comes to a general anxiety disorder medication, etc.? So again, really using the research piece or the data collection piece to inform clinical practice. The PHQ-9, again, self-administered patient questionnaire, but really looking for severity of symptoms and treatment responses. So big fan of this one as well, because you're asking, engaging patients or clients about their current symptom severity and how they're actually responding to treatment over time. So looking at it from a 2-week model. So you can see how a lot of this could be implemented even in a 2-week chunk. Again, we don't want to over rely on psychometrics. So I'm not suggesting that we should do it every 2 weeks, but for effectiveness or research study purposes, it can be. And you're looking at how many days within that 2-week period is my client really struggling and really showing symptom severity. So this one assesses a range of symptoms, looking, quite a few depression-oriented symptoms here, and really talking also about some screening for self-harm or suicidality, really opening also up the clinical conversation about these things that may not come up in a therapeutic session as quickly as if we don't use a screening tool. And then the leads, not used very often, and I'm not sure if many of you have heard about it, but it's really designed to measure dependence upon a variety of substances. There hasn't been an update to the leads. It can be very difficult to find and use, but it is, a very well-researched psychometric evaluation, but it's not used often, which again speaks to maybe just the lack of research in addictions that we see. But really looking at what are the dependence on a variety of substances over time, and how often is it happening when we're talking about drugs and or alcohol, and are we noticing them decrease, and are we noticing the desire or the relapse desire to decrease over time as well, and are we noticing an increase maybe in the ability to cope using other tools and skills. And so when we look at an inpatient measurement schedule, so CORE would refer to our general inpatient programming, looking at approximately 50 days of time and treatment, plus or minus 2 days on either side. Really, we're looking at conducting them obviously upon entry into treatment, and then we're looking at conducting them again at around week 3 to 4, and then conducting them again at week 7. We would be conducting all of the measures that I listed. This would just show an outline of the ones you could add. Alternatively, when they leave treatment, they would likely be doing, maybe just the OQ45 and the LDQ. It depends how many you're sending off. But aftercare, within our programs, we do a 1 year of aftercare following inpatient treatment. And then we really try to engage our clients in completing, when possible, as many as they can. But the inpatient measurement schedule could be set up at your centers, however you wish. And the OQ45 arguably could be done on a bi-weekly basis as well. So, now I've talked a lot about, I'm always mindful of time. I'm like, Jeremy gave me this much time and I want to leave time for questions, but I'm going to slow it down a little bit to talk about the effectiveness. So many of us are engaging in best practice, working with clients that are significantly impacted by either substance use disorder, concurrent mental health, or mental health diagnoses. And so for us, I'm going to be talking about a sample that we did. It's 708 patient sample. So it's a very large sample that when we look at research studies, oftentimes they're small sample. And the fact that they are all patients that have come through the facility is also an important point, because they are, truly a very clear population that would be struggling with substance use disorder and concurrent mental health challenges. And so these are results from our research study that we've done here, and we obviously keep collecting data, and obviously this one's out for publication, but not quite there yet because of the delays of COVID, but we're out there in the process. So when we look at why it's important to do research in this area, I did talk a little bit about it at the beginning when it comes to why are we passionate about it? Why am I personally passionate about it? There's an absence of studies that really demonstrate the effectiveness of inpatient treatment. Again, we could assume we're taking people out of, more high stress situations. We're putting them into a treatment center setting. We would assume that, they would get better. That would be a general societal even assumption. That being said, there's really not a lot of research on mental health considerations, despite the high rate of comorbidity. So we talk about, the overdose crisis. We talk about harm reduction, and I fully believe in the whole spectrum of how to treat substance use disorder. But very rarely are we also saying, what really needs to be treated here is we have very high rates of trauma and concurrent challenges and PTSD. We have super high rates of depression and anxiety. And if we ignore the comorbidity and we ignore the mental health considerations, we're really actually not demonstrating much other than we've stopped someone potentially from using, or we've reduced their consumption, or we've, made them, let's say choose a substance that from a harm reduction perspective may be more suitable for continued quality of life. And that is something that we are lacking focus on. So number one, does treatment work? But more to the point, when we address the mental health considerations, when we actually measure that we're not just treating the substance use, we're also treating what's concurrently happening from a mental health perspective, what is the success then? What is the effectiveness? And so when we take a look at the general impact of substance use disorder and treatment on the general population, I think it's really important that, like, the rates of substance use disorder are almost 2 times the rate of mood disorders in Canada, right? So what that means is 1 in 5 Canadians, or approximately 21% of our population in Canada, will be impacted by their substance usage at some point in their lifetime. And that means that 1 in 5 of us walking around at some point will have problematic substance use. That's a huge number. And what that also means is it speaks to needing to focus on how we make that effective over time and how we reduce the impact, not only individually, but societally. And as if I think about it and I look at my own family, or maybe you're thinking about people, we all know people who are struggling with substance use challenges and concurrent mental health issues, I would argue. So then when we talk about, in addition, why is it relevant? Individuals with concurrent challenges in addiction and mental health, they're obviously more vulnerable than those without symptoms of a mental health disorder. And what that means is when it's concurrent, we are more likely for these individuals to be hospitalized, more likely to have relapse occur, more likely to commit or complete suicide, more likely to experience financial difficulties, homelessness, incarceration, and legal issues. So the desire to prevent or at least treat and give someone the tools to deal with their substance use disorder and concurrent mental health challenges, it's a tall order, but it's so needed when we think about the percentage of impact and how many of us know people who are struggling. So again, purpose was, of course, to identify the lack of literature about inpatient treatment outcomes in Canada, because we really don't have literature on that is, reputable and showing what we're doing, other than marketing research, which serves a purpose and I love it too, but it doesn't have the same focus on empirical evidence and it doesn't necessarily have the same rigor. The other thing that we wanted to do is take a look at the impact of gender. And this would be gender, like what is basically identified gender has on the nature of addiction, associated psychological challenges or difficulties, and their treatment outcomes. So what do we see? Now, for all intents and purposes, these are broken down in male and female genders. We would like to expand that research as we move forward, but for this, it was really identified as male or female gender at the time of birth and then moving forward. And so just want to point that out, that will be in a continued area of research and not something that we're ignoring or just putting into a box, but that's how we wanted to look at that as well. Also speaking to what would we see in gender specific treatment? Some of you may work in gender specific types of environments or may be interested in doing gender specific treatment. And when does that actually maybe have even more of a benefit based on what people are coming into treatment with? So methods, we collected data. I told you all that already. Admission to discharge from inpatient treatment. I told you the duration, and you know that we are treating them. So what that means is our center is providing that intensive treatment for substance use disorder and concurrent mental health issues, including PTSD. And we also are looking at process addictions ranging from sex addiction, financial disorders, gaming, gambling, etc. So the features of treatment, and this is where, again, this is the description of we're saying that we think we're using best practice, but what does that mean? I think that sometimes is a term that gets thrown around and maybe doesn't have a lot of weight to it. So this is sort of providing the features of what treatment looks like from our perspective. Access to medical care, so continued primary care needs taken care of, 2 psychiatrists on staff, so looking at getting a full physical, nursing staff, continuous aid, detoxing on site, each patient obviously continuing to get psychiatric evaluations and medical exams as well. And then, of course, the treatment model is used in a biopsychosocial spiritual model. We're using different types of modalities from CBT to DBT, of course, MI, rational emotive therapy, EMDR, ART, access to 12-step facilitation, but also access to SMART recovery and also access to Dharma or refuge recovery. And then we have also looking at the individualized personalized care, heavy reliance on both group therapy and also individual sessions. And then patients are also treated, of course, from a holistic perspective, looking at nutrition management, access to fitness, access to different types of rehabilitative therapies and family programming as part of it. So we're really looking at if someone has access to this type of treatment, what is the effectiveness? So that sort of provides a baseline. Of course, happy to answer questions on more of the features later. And then breaking it down to pre-COVID and during COVID. So pre-COVID, we did a variety and then we added in more data as we went into during COVID. And now we're maintaining the more higher frequency of actual using different types of psychometric evaluations. We're using more of those now. And when I break down the research, they have been broken down properly, even though we used more studies in study 2. So the results, this is the fancy numbers slide that shows you that it's been a very significant reduction in symptoms when it comes to anxiety, depression, and emotional dysregulation. But I will flip to the non-fancy number slide. But for those who love statistics, please note the different N variables. We have 2 different sort of study types in study 1 and study 2, and then of course the means and standard deviations. But the actual significance is very, very high at 0.00. And so what we saw here, if we look at, which will be listed, levels of psychological dysfunction in patients admitted to treatment compared to pre-COVID, right? And inpatient treatment results in significant reduction in addiction symptoms and improvements in psychological well-being in both study groups. But they will be in more. So here, this is I'm more of a verbal person. I like numbers, but it's fun more to describe it. So what's interesting is when we looked at anxiety, significant reduction. I mean, it was shown in the numbers, but here it's very clear. Significant reduction in anxiety when someone would leave treatment. Significant reduction in depression when someone was leaving treatment. when we look at average levels of emotional dysregulation. So what that looks like is how emotionally regulated am I? How quickly can I return to baseline when I get dysregulated, et cetera? And we're seeing a significant reduction in emotional dysregulation levels. And then another interesting one, reduction in substance cravings are significantly reduced. And so in our center, we obviously have access to medically assisted therapies and OAT therapies, et cetera. And so cravings are significantly reduced. And one would argue there's a correlation between, intensity of treatment and skills and substance cravings. But again, we can hypothesize later together. And then effects of gender. So these I found super fascinating. So females came into treatment with higher levels of addiction and higher levels of psychological dysfunction compared to their male counterparts. And another interesting side effect was that they experienced greater reduction in addiction symptoms and greater improvements in emotional regulation as compared to males. So not only did they arrive with higher levels of addiction and psychological dysfunction, they also left with a greater reduction in symptoms. So that was interesting. You saw much greater variables there. No difference in score for marital status, no differences in scores by employment status, which is also interesting. And then when we looked at prior trauma upon admission into treatment, it was associated with greater improvements in psychological functioning and decreases in addiction symptoms. So what that means is that if someone identified prior traumas upon admission using the variety of tests, we would see greater improvements, which spoke to using different types of modalities that are trauma-informed and trauma-focused. We could actually see increased psychological functioning and decrease in addiction, which further correlates, in my mind, the addiction and trauma connection, which I know many of us are seeing very actively in our private practices or our treatment center settings. So that's a whip through that. So now, when we look at the determinants of success in recovery, something that we talk about very clearly is there's always sort of not always, many times a belief that it's easy, quote unquote, to stay active and engaged in a treatment center setting versus when we leave. And it is our responsibility as practitioners and providers to really provide our clients or our patients with an understanding and access to the term recovery capital. Recovery capital, thank goodness, has taken on a lot more of a buzzword term. Some of you may be attending the Recovery Capital conferences, both across Canada. The next one's coming up, I believe, in Calgary in April. But recovery capital became a really important concept because it said, here are these human and physical factors that are necessary. Here are these social and cultural factors that are necessary. And we need to build capital in these areas in order to improve the determinants of successful recovery. Now, recovery defined as the person that is served defines it, okay? So it doesn't need to be abstinence-based per se. It can be harm reduction, et cetera. Like, we're talking about the whole spectrum. But what it identifies and what this slide is really meant to do is show you all the different factors that are included in recovery capital, of course, from housing to employment to nutrition, but then other things like mental, spiritual, and emotional health, or what personal resources does the individual have access to, or am I helping them find access to in a therapeutic process, mindfulness, financial responsibility, well-being, coping skills, etc. And then in addition, from a societal or cultural perspective, what are we seeing the individual return to? Are they having access to social support? Are they having access to community attitudes that are inclusive, reducing stigma, diverse recovery role models? So are we also allowing our clients to access what they believe recovery is to them and finding role models for that purpose? Do they have access to recovery communities, recovery supports, oftentimes in the form of meetings, and there are now, thankfully, a diverse range of meetings that are useful to many people, from AA to SMART to Dharma to LifeRing to really just a collection of resources. What is a connection to purpose? So not specifically what does each individual have to do for them, but what is the higher purpose and what pathways are available for continued recovery and access? So we also measured recovery capital, and I would suggest that there's a large importance to doing so, because what recovery capital does is it shifts the focus, right? We stop pathologizing addiction. And I think we've come a long way. And then I hear people talk about addiction and I think, holy crap, like maybe we haven't come as far as I thought we have, because really we need to focus on assets that individuals have that are required to both initiate whatever the change is and sustain long-term recovery. Again, whatever recovery means to that individual, but initiating too, right? Like it is very difficult to make those types of changes, but also when it comes to living a life that individuals want to live, how do we help shift that focus? How do we stop that pathology? And some of the studies show that are currently in existence that a greater degree of recovery capital is associated with better outcomes. I mean, that makes logical sense, especially when we're looking at addicted populations. But the outcome study that we did also showed that there was a significant negative relationship between recovery capital and all dimensions of psychological functioning and addiction. So what that meant is across all of the different studies that we went through and all of the different scales, when we looked at high recovery capital, when we looked at somebody with access to high recovery capital, we saw very, very, great forms of psychological functioning, and we saw great amounts of addiction reduction, right? And so that indicates not only is it associated with better outcomes, but it's associated with greater psychological functioning, right? Which is very cool. And then we also look at greater symptom reduction associated with the increase in recovery capital. So from that perspective, it really begs the question of, when I have somebody in my practice, treatment center, et cetera, not only am I giving them the tools, the clinical pieces that they need maybe to live and thrive and cope and challenge their emotional regulation issues, but am I also taking into account all the little pieces of how I can increase agency and increase engagement and increase access to community support, and really the importance of us really arguably all working together to make that a possibility. So that's my plug for recovery capital and various outcomes. So I was supposed to finish talking by 9:45, and Jeremy, it looks like I did that. So now I think we're going to open it up to questions. And yeah, I guess I hope that was relatively useful and not too quick, but.
Yeah, no, you did a great job with timing. You actually have 1 minute to spare, so even better. Under time is the best.
Under time.
Yeah, perfect. So yeah, we can jump right into questions if you want. We have some questions about the age range of your clients that were part of the study. The person is curious, as they work with youth, typically age 16 to 20. So wondering if the stats are applicable to that age range.
Yeah, so great question. The age range itself ranges, so the clients that we would see range from 18 to approximately, I would say, 65. That being said, there's a median age, we're looking at around 28 to 32. What we can also do is pull out the age range of, let's say, 18 to 24 and give you an idea. When we went through the data, we did not see a significant difference based on age. So what I would argue in that capacity is that it would be applicable, and what would slightly look different is the therapeutic modalities used potentially, and also what recovery capital would mean. But the concepts were the same when we pulled them out. Unfortunately, we didn't have any 16 to 18 range though in the study, or in our center for that matter.
Perfect. Thank you. And then there are questions. Curious about your thoughts on the impact of length of stay on client outcomes and progress along with aftercare continuing care. I know you kind of touched upon this, but if you just want to expand.
Yes, no, my thoughts, I'll keep them contained. So length of stay to me, I think is important. When I look at, so we have a variety of beds, and when I look at severity of addiction or substance use disorder with concurrent mental health, I see increased length of time in treatment, leading to more stability, both from a mental health functioning perspective, but also from a symptom severity perspective for addiction. I'm a big believer in the therapeutic community models. Also things like extended care or supportive recovery care over a period of time. It doesn't need to only be inpatient treatment that gets extended by a length of stay, but access to recovery support I mean, I would argue to make it very like sort of open forum, like the longer the better when there's access. That being said, like the access can be the challenge. Yeah, and then it's about the aftercare pieces of what sort of a plan do you set up with your clients or patients when they leave treatment so that they still can access even free community supports in a way that is sort of rigorous enough to keep activated in their own recovery journey. So I hope that answered that question.
Yeah, perfect. This one isn't necessarily a question, it's more commentary, and I guess you can expand on it if you so wish. So whenever we wish to refer a patient for mental health issues to the mental health department, we must fill in a referral form. If they have addictions, they will not see them. They suggest that they want the person to, quote, deal with the addiction first.
Yes, so highly frustrating. We experience that often too when it comes to potential community referrals. Like it's impossible if you have a concurrent, so it can become a bit challenging if you have a concurrent mental health disorder, but you're also using substances, to try and deal with one without at least addressing the other is a very, it's an impossibility. It doesn't make it very easy for the clients in question. So I think there needs to be potentially some stability before you would dive into trauma work or deeper mental health work when it comes to dealing with the issues. But to expect, I think, the substance use to sort of disappear prior to engaging with the mental health issues is yeah, I totally feel your pain, I guess would be how I would word it, because it's very frustrating to try and explain that even to someone who is struggling, not to mention the fact that a lot of the substances that are used manifest or look like a mental health challenge. If I look at, let's say, the consumption of alcohol, it's a depressant. It is not uncommon to have somebody show up with symptoms of depression due also to their consumption of a depressant. And so it becomes really a chicken and an egg scenario, and it's very frustrating to deal with.
Yes, absolutely. And then our next question, do you have any insights on how continuing care and community support may help facilitate sustained recovery, particularly in housing and connecting individuals with community-based supports after discharge?
Yeah, so if I look at it from like a research or empirical perspective, the higher the access to continued support in the community, the higher the success. And so when I look at that, like when we look at how we're pairing people with community interventions, the research says that if we can do that, we're going to see higher impact. We also see that aftercare or continued engagement with aftercare-like services actually is one of the largest determinants of success when it comes to post-treatment outcomes. And again, whatever recovery means for that individual, but that would be the more engagement there, the better. If we simply have patients who leave, let's say, treatment or even private practice and do nothing afterwards, we see typically the potential that it's going to be much quicker that symptoms maybe return or severity of something returns as well.
For sure. And then just a follow-up question from that. What does the aftercare program entail?
Yeah, so the aftercare program that we would provide is once a week, a 2-hour aftercare group therapy session. Plus there's, so for our, let's say for our patients that we're talking about with EHN, they have access to like a recovery tracking application on their phones, smartphones, tablets, computers, whatever they use, which also helps them track what recovery capital they've decided to access when they leave treatment. So are they engaged in recovery meetings? Are they, maybe seeing a one-on-one counselor? Are they tracking some of their triggers? They can track their emotional state or their emotional regulation challenges. And they can put in different pieces that meet some of the mindfulness criteria. So they really develop like what we call an aftercare plan, but that can include anything from I'm going to do mindfulness for 10 minutes a day. I'm going to attend, 2 recovery meetings a week. I'm going to attend my aftercare group. So it's the aftercare group itself plus the aftercare plan that we find lead to really continued success and increase in positive treatment outcomes.
Perfect. Thank you. And then we actually have a question from our last webinar presenter, Selena. So Selena, thank you so much for joining. Just curious, in your opinion, which groups have been most impacted by COVID who have come to use the resources available in treatment?
The groups that have been the most impacted by COVID. Oh, that's so. I mean, I would be hedging a bet because the research is really only showing the general statistics. So the research is only showing that those with substance use disorder and concurrent mental health will have much more intense difficulties if they had a COVID-19 diagnosis. And in addition to that, when we looked at our research results that looked at pre-post COVID, it was significant for all the patients. Like, we didn't have to pull out a specific group. So anybody coming into treatment showed significant higher rates of psychological dysfunction and higher rates of addiction severity. So that would indicate that everyone was impacted. And so it's hard for me. That's a great question, Selena. And I think as COVID research continues, I think we might be able to suss it out a little bit more. I know that when we talk about qualitative data, so when we're looking at interview questions, et cetera, parents were very adversely affected. People that had to care for children at the same time as caring for homes and not being able to work. So we saw parents basically who did not have access to care, childcare or school-based care. And in addition, we saw, quite a severe connection to our first responder population as well, which we do separate treatment on, but at the same site. And so that would include any first responder population, including nursing and really those two groups we saw some amount with, but I wouldn't be able to speak to more than that. So I apologize if that's not detailed enough, but.
No, I think that's great insight. Thank you. Are there versions of the measurement tools that are not dependent on literacy? Example, inability to read/write, language barrier, vision impaired, neurodiverse, etc.
Yeah, so great question. So psychometric testing has not evolved as we would love it to have evolved when it comes to individuals with differing abilities. So my short answer to that is no. In our center, anybody that would have a language difficulty or a like sort of reading difficulty, we would read the questions to them and have them answer them. Again, though, that's not as useful as some other options. And that being said, some of them have been translated also to French, which from our perspective nationally has been helpful. But no, I mean, we're maybe getting there, but really the development of psychometric tests, at least for this purpose, has not evolved as quickly as it needs to.
Looks like we have time for one last question. So do you measure recovery capital before, during, after treatment? If so, how?
So there's a recovery capital scale that we use, and it's publicly accessible. You can Google it, we can send it to you, whatever works there. But the recovery capital scale is a validated tool, and we do use that at the 3 points across treatment to actually show that we either increase access to recovery capital by the time someone leaves treatment. Typically, when they come in, they may not actually be aware of even the term. And so, yes, we would measure it, and there is a very easy self-administered scale that can be used for that purpose.
Awesome. And then just a follow-up about when you were talking about aftercare, the app you mentioned, is it available for everyone, or is it only EHN clients and patients?
So it is something that can be accessed through our EHN online services. So I think there'd be maybe a link that we could send out, Jeremy. I'm not sure within our sending out of whatever you're sending out next week, but it's included for people who complete an EHN program. That being said, they're looking at opening that up in a different capacity for access to public forum, et cetera, but it hasn't been fully established yet.
Yeah, and as you mentioned, I'm going to include a bunch of resources as follow-up. So I will be bugging you via email for more resources. So yeah, it looks like that's it for questions in terms of time. Thank you so much, Christina, for a very informative presentation. Just to echo what everyone's saying in the chat, great, insightful, informative, lots of different terms being tossed around. So thank you. And your research is second to none. So thank you so much again for sharing with us.
Thanks, you guys. Thanks for having me.
Of course. And for everyone else, thank you so much for attending today's webinar. As mentioned at the beginning of the webinar, this webinar was recorded, and we will be sending out a follow-up email sometime mid to late next week that will include a copy of the webinar, copy of today's presentation slides, any additional resources that I will follow up with Christina about, and then your CEU certificate. We look forward to having you at future webinars. Take care.